The talk that I'm going to present is on an app. The app is called NHSquicker. And so my name is Nav, and I have been, the product owner of this app from 2017 onwards. So it is a long-term project that I'm going to talk to you about. Uh, and other than of course, the NHSquicker work which I do, which is mostly, I look at it from the perspective of, getting data for my research. Other than that, I'm also the professor of analytics and operations management in the University of Exeter Business School. So I have been in Exeter for almost 11 years now. And so this app is for shaping demand for urgent care services, and how and it's going to I'm going to talk to you about the different stages that we have gone through working together with the NHS to realize this app. Uh, okay, so the outline of my presentation. So I will discuss a bit about the urgent care network. I mean, most of you will be familiar with it, but some of the slides are, for academics who are not working with the NHS, right? So yeah. Then I'll talk to you about the early motivation of this work, which started with Torbay and South Devon NHS Foundation Trust. As you know, Exeter is in the southwest of England, and Torbay is one of our closest trusts. So yeah, I'm going to talk to you about that, and then I talk to you about the more research element of the work, which is about how we are using nudge theories in order to design nudges to help spread the demand for urgent care. I'm going to talk about some of the features of NHSquicker. Uh, so the NHSquicker, so it was launched in 2017, and currently we are version 3, right? So it has had a long history, and as new versions have come in, we have had new functionality integrated into it. And from the research side of things, obviously, what is important to me is the evidence of efficacy. So NHSquicker I see is a tool to see whether real time information can help inform the patient's choices in terms of urgent care. Whether it is the platform NHSquicker or some other platform, some other app, is not that important to me, because the idea here is about getting the evidence to present to the community that yes, real time approaches uh, uh, do work, and people are then taking different decisions, right? And in future maybe there would be other apps, and there are already some other apps which do around the same things. So yeah, so evidence of efficacy, and then I'd like to say a word of thanks to all the collaborators who have been involved in the project, from early on. So just to provide the context, so we know. So this area is obviously the Devon area. So we know that our urgent care network of a trust comprises of usually, at least for acute trust, one or more accident and emergency departments, and then which are for obviously for life critical limb, life and limb, you know, facility, services. But also there are dotted around the around catchment of a trust. There are also minor injury units, urgent care centers, walk-in centers, and so on. They are all non-appointment based, but the idea is obviously that people who require emergency care go to A&E department. For minor injuries, so maybe bruises or headaches, or even if there is a need for an X-ray and other conditions, then you may go to a minor injury unit. In some cases, you can go also to a walk-in center, but in walk-in centers will not usually have an X-ray. So this way, then the users have a choice of which facilities to go to. and yeah, and for appropriate facilities for appropriate urgent care needs. But as we know, the A&E wait times are increasing. It's in the headlines all the time. Uh, so 4 hour waiting time, and I think the attainment of the 4 hour wait time is now among the lowest in the last 10 years or so. So yeah, and again, I'll show you some data, maybe in the next slide, I think it is, to show that how the whole urgent care network performs if you also take into consideration not only A&E, but also the minor injury units. So I'll then start with the motivation of the work. As I mentioned that we started the work with Torbay and South Devon NHS Foundation Trust. So my research expertise actually is in computer modeling and simulation, which is a part of operations research, right? So my work looks into the deployment of, let's say, discrete event simulation models, agent-based models, system dynamics, to try and understand better and make better and more informed decisions. So that is the area of operations research. So when this work started, so at that time I was looking into the modeling the A&E department of Torbay Hospital, and then looking also at the other urgent care centers, it became evident that the attainment of 4 year, sorry, 4 hours, sorry, 4 year would be too much, 4 hour targets, the MIUs, minor injury units, were doing consistently better. So we started looking at some of this data. What you see on the screen, maybe I can just bring my pointer. Yeah. So obviously, here, the territory, if you can see the pointer on the left-hand side. So this is Devon and Cornwall. So I'm highlighting the area where which is under Torbay and South Devon NHS Foundation Trust catchment area. So here at the time when this work started, yeah, 2017, at that time they had one hospital, one A&E hospital, Torbay, and then dotted around the catchment were several minor, injury units like Brixham, Dawlish, and so on and so forth, Newton Abbot. We have done a postcode analysis, right? And we see that obviously, and maybe what is to be expected, especially when especially when patients are not fully informed of the other urgent care facilities, that people who are near the hospital, right, near a certain facility, like Torbay Hospital, the majority of the people are coming from those postcode areas. In the same way, if you look at Newton Abbot, so majority of the people, this pie chart showed, are coming from Newton Abbot area, and so on and so forth, right? So this is okay for MIUs. Obviously, we want, these are geographical facilities, and so, and if people are coming to MIUs, that is good, right? But in terms of the emergency department, this may not be the ideal condition. If we see that most people who are around Torbay Hospital are going to Torbay ED, because there are because many of them probably don't need to be in ED department, right? So and also considering the cost of visit. So these are the NHS tariff costs. This is from 2018. A visit to the MIU or urgent care center is £67, walk-in center 46, and A&E visit, the tariff rate is 114. And this was in 2008. There have been revisions since then. So then, if it is possible to, to redirect people, to inform people of the other facilities which can serve their urgent care need, but not emergency. If it is emergency, obviously we need to be in ED. Then it might be possible to, to reduce some of the demand for A&E services, right? Overcrowding of A&E. But then we also have to know what is the status of the MIUs, right? How good, in terms of the 4 hour waiting time measure, what is their performance? So we looked at that. So this is again for Torbay and South Devon, and this is from this is old data that we analyzed. As I said, it's a quite a old project, and at that time, as I mentioned, they had like 7 MIUs. Yeah, Dartmouth, Teignmouth, Dawlish, Totnes, Paynton, Brixham. These are all MIUs. Currently, many of them have closed. In Devon, we only now have 3 MIUs and one, Torbay Hospital, right? Torbay ED. Now, if we look at the 4-hour, if we do an analysis of the 4-hour breach rate, right? What we see is that in emergency department, the breach is around 25%, right? Of 95%, which have to be seen or treated or discharged within 4-hour target. For MIUs, actually, it is less than 1.5%, right? You can see the breaches here. This is the 4-hour. This is a stacked histogram. This is telling you the minutes, right? And then we see that 25% people in Torbay Hospital at this point in time, when we analyzed the data, there was a, couldn't, it was over 4 hours. But for the other MIUs, it is negligible. So this kind of, obviously thinking about it, then there is some capacity in MIUs. They could probably take more patients, right? But then that is only the case of Torbay and South Devon. So what about the national picture, right, in England? So we looked at the national picture, right? And this data is from February 2020. So now we are talking about 132 trusts. Here we were talking only of Torbay. Now we are looking nationally, 132 trusts. The breach rate of ED is 27%, 27%, which kind of reflects what we have seen in our local trust. For type 3, which is type 3 A&E, which are MIUs, the breach rate is 1.4%, right? Which is similar to, what we had. And on top, so this data for obviously the national data sets is coming from, NHS Digital. We also found that, 9% of ED attendances, right, who come are discharged, yeah, without requiring treatment, and around 32% receive only guidance. So around 40% of the people will not need to be in ED, okay, will not need to be in ED. Now, when we look at, we did a survey in Torbay and South Devon of people, from their secondary data, how many people, didn't really need to be there. So there we found during this time, right, 2015-16, the 30 to 40% of ED, they were given a triage category of 4 or 5. So which again, matches up somewhat to the national picture if of 132 trusts. If you add up 32 and 9, so 40% of people probably did not need to be in ED. So what we see here is there is some existing capacity, even nationally, in MIUs. And second, a lot of people, 32 to 40% probably don't need to be there, right? Some of these figures need to be updated. I wanted to update, but I just didn't find the time. But but the picture has not changed. I can tell you that. So then we thought that if we were to think of reducing overcrowding through redirection of patients, then probably the solution that we want to develop should be something which is scalable, right? Which could be used by other trusts as well, because nationally the picture is about the same. So the aim of the work is then to reduce demand for A&E facilities with the objective of redirecting less serious cases to the minor injury units, urgent care centers, walk-in centers, right? And by doing that, what is happening is that the demand is being shifted, right? But then a question can be asked that if too many people are sent to MIUs, urgent care, then the waiting times there are going to increase, right? Although and then A&E facilities may then show a lower time. Therefore, so first is that if the care is for urgent but non-emergency care, MIU is probably the best place. But still, if we have too many people being redirected to MIUs or urgent care centers, if we have the real-time data, right, then the system balances itself. Thus, if more people are being treated than are moving towards MIU urgent care, then from the data which is updated in our system every 5 to 15 minutes, then the patients can then see, which facilities are busy, right? And then they can take appropriate decisions that way, right? But A&E still is for emergency care, right? So in order to, for this research, then we then had two objectives. One, we were looking at the trust focused objective, which I just said that we now need to look at a whole systems in terms of urgent care, the different A&E and MIUs to be seen together, because our data has shown that, yes, there is some capacity in MIUs and a lot of people don't need to be there. So this is a trust focus objective, how through patients' own decision making, patient empowerment, they decide from there where to go, right? And which then levels demand. The second is, of course, also important is the objective of the patient, right? I am sure, most of us would not want to go and, go to an emergency care facility and wait for 2, 3, 4 hours, right? And also sometimes you may see that there are not too many people, but then you go there and then obviously there is a triage happening, and the nurse knows that the person probably doesn't need to be here. So your triage category becomes 4 or 5, which means other people, children, and with more serious conditions who are in MIUs, who are in, A&E departments, they are obviously, they'll have a greater priority, 1 to 3, let's say, not one, or one is for research, right? 2 and 3. And so you will just keep on waiting, right? Although you may see that the emergency department is maybe, relatively less people, but still other people having. Therefore, there is also a patient objective here, right? Because obviously the time is an opportunity cost. So with this work also, we are trying to encourage patients to not only help the trust to level the demand, but also thinking of their opportunity cost in terms of time. The choice is, right, are you prepared to travel further to be seen quicker? And again, I'm coming back to the Torbay Hospital example, where we see through a postcode analysis that most of the people there were from postcode areas which were near Torbay. And many people didn't need to be in ED. Obviously, they are going to the ED department because they are in Torbay area. Even they probably know that their case is, minor ailment, but they see Torbay is 5, 10, 15, 20 minutes. So therefore, it is important then this solution to also integrate something of travel time, distance traveled, things like that. So, and through this, we are trying to nudge people to go further away to be seen quicker, right? So these are the two objectives. The originality of operations research method is that we are using real-time data to design the nudges, right? To be delivered. And these nudges are personalized nudges to inform people where might be the best place to go, taking into account also their present location. So so this is using nudge theory. So if we so nudge, it is based on the idea of shaping the environment by making some choices to the choice architecture, right? So the thing is that the basic premise is that we are overloaded by information. And then if we can, we can present some of the information to the users, which are, and for which, there is not too much of cognitive overload, right? And also can help to them to take better decision, then we can nudge them towards that. And there are different intervention ladders, right, that you can use in order to make people choose a certain, right, a certain a certain choice. So if we talk of A&E departments, we may say that, okay, there could be that if patients are coming to the A&E department, then if the triage nurse thinks that they can go to MIU, then they will simply be redirected there, right? So there is no chance for them to be seen there. That could be one, but that is, applying too much of, the very forceful kind of thing. The other things which can be done and has been done in some European countries is that if you go to an A&E department, then there is a certain surcharge, right, to be seen in A&E departments. There are also cases where if you are in, if your case is a urgent case, urgent care, but does not require A&E treatment, then you have to pay something extra, right? But obviously in NHS, none of that is implemented. So there are different, there are different interventions which can be done, right? And nudge is a very subtle way, right? So this is what I'm pointing to you now, that NHSquicker, what we are trying to do is we are trying to guide the choice by changing some of the default options, right? By default, we mean that choices which are presented in such a way that people are likely to use that, right? So one example in nudge, a very well-known experiment is that, to make people eat healthy, what some of the studies had done is they seen that, if you in a supermarket, if you keep fresh fruit and vegetables, right, in the level of the eye, right, in the top shelf, and then if you put non-healthy, let's say, products like, sugar, candies and things towards the bottom, and they have done some randomized trials and all, then obviously what has happened is that people that what you say that the people's default has been changed that way, just by placing things in a different order, and then they see from the data that more people purchase fresh fruits and things. So these are very subtle choices, right, that we can change to make a small change in the choice architecture, right, by changing the defaults. And there was a Nobel Prize on the nudge theory. Thaler received a Nobel Prize, a few years back on and this is the book. Yeah, The Nudge: Improving Decisions About Health, Wealth, and Happiness. One of his books. Is obviously also esteemed scholars with a lot of research papers. So how are we deploying nudge in NHSquicker? So we are using real-time data to inform the nudges. This real-time data is on the state of the A&E department, like the number of patients waiting to be seen, how crowded how many patients are there in the ED or MIU, urgent care center, the maximum wait time. And also, because I mentioned about the second motivation, that patients, it's important to communicate to the patients the waiting time, right? And also taking into account the fact that we want them to travel further to be seen quicker. Therefore, we also get data on real-time traffic information from Google, right? So that, when we show the wait time, we add both the waiting time from the A&E departments together with the time that is needed for them to travel to that center, right? Because we want to push them further away. So if we can show that, say if you travel, if you have access to car or public transport, bicycle, whatever it is, if you travel 5 kilometers away to be seen, significantly at a faster rate, then probably people will choose that. Yeah. So right. So this is the version 1 of the NHSquicker. We are in version 2. I'll show you some of the new screenshots. So I'll just give you an example. So I took the screenshot when I was in Exeter, so in this office actually. And RDNE, Royal Devon and Exeter Hospital in Wanford, is the one which is closest, 3.3 miles. Then we also have Newton Abbot Hospital, which is basically an MIU, right? And we can see the wait time here, 1 hour 14 minutes in the emergency department of RDNE Hospital, which is much closer to me, versus Newton Abbot MIU, where the waiting time is only 36, right? We can see the patient numbers, 46 versus 2. And then our default in the nudging is basically we show based on the combined journey time plus the waiting time of a facility. So by combining journey time and waiting time, we are saying that the person estimate will take 57 minutes, right? So journey time plus wait time. But if they go to RDNE hospital, and which is much closer, right, and use the same means of transport, it is going to be 1 hour 27 minutes, right? And we are sorting this out in ascending order, and that is the change of the default that we use in the nudge. So we create these tiles and we show in the top right the one which has a combined journey and this time. Now let us say there are 20 centers, which this app picks up, then we are trying to reduce the cognitive burden, right? For the person to go through each of them and trying to make a decision, right? But if it is for, if it is for urgent care, but again, this app is not for emergency care, for urgent care. By combining this together, we think the options, the options, at the top are the likely options they will go to, right? So yeah, and then we can get other information as well. If you can, yeah, you can change your mode of transportation and so on and so forth. So this is the basic idea. Now I'll talk more about the architecture of the app. As I mentioned that we wanted an architecture which is scalable. So you have an NHSquicker app, which is evoked, and then there are dotted around the territory are several MIUs and ED. The algorithm will show you at least now it is at least six centers of urgent care, including ED, right, which are open at that time. Now we know that MIUs also have some non-routine closures, right? So with the new version of NHSquicker, we have integrated it with the with the national DOS service. So if there is a non-routine closure of the MIU, then obviously it has to be reported to NHS Directory of Services. And then before showing the results, right, NHSquicker will first query DOS and based on that alert the person, where to go. And what's happening is that how do we get the real-time information? So every trust, right? Let's say there are 3 trusts here, NHS trusts, they pump data to our backend service, right? Through their automated system. Nothing in this system is manual. It's all automated. So there's a high level of integration. And they pump their data according to a certain format. And then NHSquicker, when the app is evoked, it goes to the server and there's algorithm to decide, to order the available choices and nudge and use the nudge approach. Now, when we think of scaling this up, and this is also a very important part of this work, is that, as I mentioned, that we see that Torbay and South Devon, the data that we see is kind of reflected nationally. But now, when we talk about automated system, we understand that NHS, have got the trusts have the autonomy to select the patient flow systems which are in use in A&E departments and MIUs, right? And there could be several different patient flow systems. Like EDIS is currently, quite popular in southwest of England, but Patient First, Symphony, Track Care. So these are all system, Adastra, right? These are all systems which, once we go to a MIU or A&E department, they enter our records. And as we move through the different processes, your record gets updated, right? And this is from this record itself, we are able to calculate the waiting time and other things. But yeah, there are multiple systems. And if you talk about, this number of trusts, then, we need to have an approach through which our system can receive the information. And obviously, these systems are based on different databases. So what we found during our research was that there is the obviously NHS data model for accident and emergency commissioning set. So what this means is that irrespective of the system that the trust supports, right, then certain things must be available. Yeah, all of them should, because they have to report to a certain standard. They must be capturing certain information. Like, for example, you can say A&E, department type, arrival date, and things like that, many others. But basically, this then told us that, okay, if we have a solution and some APIs, the application programming interface, then we need to develop some fields, right, which are captured by everybody, right? And then that becomes a standard. So we developed the NHSquicker standard for data, right, which is basically the format that is used by different trusts, whoever want to join the network, to push data to us, right? It's a JSON format data. So yeah, so this is a data standard. We also have a backend, CMS type system, content management type system, which allows us to add new trust. Yeah, you see here new item, but this is basically a new trust. We can add a new trust, give them the API details, and then we can also add obviously for authentication and all of that. And as long as they provide us data in a certain format, NHSquicker will be able to pick it up, right? Things have become a little bit complicated now because we have got the DOS integration with with NHSquicker 3, and which means that any trust who want to join NHSquicker project will also need to bring in their lead, their DOS lead. So every region has a DOS lead. So like we are working with the DOS leads of Cornwall, Devon, and Somerset, where the app has coverage. So yeah, so that is one additional thing which has happened with NHSquicker version 3. I'll just talk about the development of the network. So we first worked with, so this is a very, organically developed network. So we worked with Torbay and South Devon, and then RDNE Hospital, North Devon. Now North Devon and RDNE have merged together. SW, ASFT, Southwest, Ambulance Trust, they operate a MIU. Then we work with Plymouth Trust and Royal Cornwall. So this is still 2017. Since then, the network has expanded. I think I will quickly say a few more things now. So we developed a network called the Health and Care Impact Network, where we brought in people from these different trusts, right, to develop this the data standard. The second photo is very important because these are actually the people who are mostly the analyst people with whom I'm speaking now, probably now. Yeah, all of you are analysts and people looking into business intelligence and databases because they knew what data could be sent. So we developed this format, right? A shared format for communicating, for pumping the real-time data to our system. So now some evidence of efficacy. So this was part of also a study called the impact case study, which is some kind of an academic exercise which happens after a few years. So we want to capture how has NHSquicker kind of changed the landscape. And for this impact study, we had different types of assessment points, right? And I'm going to present some of them. So we had some questionnaires, and you can see from the questionnaire, and this questionnaire is actually quite recent. You could see that what the respondents were saying, because the questionnaires are integrated into the app as well. So we always have a live, we know what the people are, we are able to analyze the questionnaires. We have some Python programs. We just download the data and we analyze. So it is a continual process of capturing data. So 75% of the respondents, said that they would use this app again. 70% said they would recommend to a family and friend, and they use the app to learn about alternatives. So acknowledgement of this slide is actually to a couple of people from the NHS, Rachel Shine and Sebastian Lawrence, who we are working with for NHSquicker 3. So we give them the data and then they create it for internal dissemination, I think. Some other, some other information points about the experience. The 98% of respondents says that NHSquicker changed their mind. Yeah, and so on and so forth. So if you look at another data point, which is about how did they find the NHSquicker useful, and you can see their response. Most people said that they came to know how busy they were. Some people said they gained knowledge about their condition because there are other features in the app as well, which I'm not going into. Some people also said, see, I found healthcare services near me, 241 responses, which means that they were not aware of the other MIUs which they could probably go to, right? So yeah. Oh, okay. Then we also did some analysis. This is very early on analysis, 2017-18, of the trusts which adopted NHSquicker. And we could see there was some movement, right? That this is a quarterly analysis from this point on. So compared to 2015-16, where the MIU attendance was minus 6% and the ED attendance was +6. After the launch of NHSquicker, right? The MIU attendance increased by around 8%, and the increase of the A&E department was relatively less. But we have to understand that at this point there was a lot of publicity of NHSquicker, right? Because for this to work, people have to know that an app exists and they have to keep the app, right? It's not like some other healthcare apps like for cessation of smoking where you are using it every day. So it is an app that you must have, which hopefully you don't need to use it, right? But you should still have it. So there was a lot of publicity at launch, and therefore we could pick up the signals from the secondary data. Second thing I should say is we don't know that all of this increases because of NHSquicker, right? Because the environment is changing. There is sometimes funding for winter pressures, right? And and many other things are happening in the system. But if this increase, this change, if 10%, 15%, 20% is as a result of NHSquicker, it is still a very big amount, right? So that is what I just want to make it clear. We are not saying that this is all because of NHSquicker. Similarly, right, if you look at Torbay and South Devon NHS Trust, after the NHSquicker launch, after a few months we started, when the publicity campaign for this was increasing, we saw that there has been a huge increase in the adoption of MIUs, 10%, 10 to 12% increase. And again, not all of this can be attributed to NHSquicker. We know that. Therefore, to capture this information, that what is the impact, we are using not only secondary data analysis, but app analytics and many other things as well to try to triangulate the evidence. Okay. So yeah, so just to say how it affects, right? So this was sometimes shown in the BBC Spotlight 19th May. And at that point in time, I kind of captured the data. So at this point, the person in the news is actually showing our app, right? NHSquicker. And at that point, you see it just spiked. Yeah. And you can see the usage in the last 30 minutes. So more than 3,000 people used it because it was being shown in the television. So they were downloading the app and they were using it, right? But so compared to that, our usage for a day for 7 days is only 2.5K, and in 30 minutes we had like more than 3,000. So this shows that for this to work, right? Obviously, for this then this solution to work, there has to be constant dissemination of this approach so that people know and then they keep the app. Another evidence of efficacy is how we have developed the network over the years. You can see, new trusts have joined in. And again, this is to be updated. But currently we have 37 urgent care facilities, including 7 MIUs, which have got different, these are the names of the systems that we have integrated: Symphony, Patient First, Track Care, etc., which provide this data. So yeah, so October, as of now, 37 urgent care centers, including 7 A&E departments. It now covers Devon, Cornwall, and South and Somerset, 2.2 million people. And we have in-app questionnaire, and we have got an award as well. So in conclusion, then what I'd like to say is that this work has been developed, co-developed with the NHS Trust over several years. And it is a local solution which is trying to scale up and trying to support the delivery of 4-hour, the 4-hour metric. We using this real-time data and nudges, we like to spread the load of NHS of urgent care across the system. We want to leverage data which is already collected, because the data that we are using that is being sent to NHSquicker is nothing special that the trusts are doing. They are just opening it up, right? But obviously, to open up this data, they need the approval of the chief executive and the chief medical officer. So those things are there, because once the data is out, and if there is a problem in the system, right, then the wait times will show abnormally high. So there have been cases where a person, checks into the A&E department and then after that leaves without informing them. So that person is still there in the system, right? And therefore, when you are calculating the maximum wait time, that person's time is reported, right? And so the time becomes like 8, 10, 12 hours, let's say. Maybe some of this is now even normal, but let's say 24 hours. So once the data comes out, then there has to be a concerted effort from the ED and the maybe the senior management to look at this data and check the feeds. Obviously, we also report if there are any problems with the feed, and the system architecture that we have developed, and we have shown it to operate through the last 7 years, right? Continuous operation from 2017. We know that it works, it scales up. And the last thing is about behavior change, right? Currently, what we are doing is we are, showing them the app and nudging them. But as people become more aware of the other centers, and even if they don't have the app, then it would be, then they draw a connection that, okay, you know what? I really don't have need to be in any department. So, okay, I don't have the app, but I know that it is better for me to go to MIU or urgent care center rather than ED. And indeed, many people, most people may be working in the healthcare system, in the A&E departments and all, they already know that. But maybe those who are not in in the NHS, right? They don't draw that link or know about the existence of certain centers where they can go to. So this is what I'm saying, that in the long term, probably, it is more about the change in behavior, even without the support of the app, that people understand the kind of condition they need and make appropriate choices. And finally, of course, I mean, this is free to the public. And I just want to say some words of acknowledgement. Of course, I mean, the platform has been developed over several, very small grants, right? So you see total of 85K and coming, yeah, so from different sources at different time. So several academics are involved. Alison Harper, Surajit Todd, Tom Monks from the University of Exeter, Susan and Andrew Fordyce, with whom we started the work back in, many years now. Currently, we are working with NHS Devon ICB, Mark Jeffrey from NHS Devon, who is the DOS lead, Sebastian Lawrence from NHS England. The idea is to scale it up, and that, and many other trusts. And finally, this work has, has won some awards. The most important from the academic side is the Lynn Thomas Award for Research and Impact, which is given by a scholarly society. We have, articles published in several places. HSG Award, which I think many of you know, we were a finalist. That was very early, 2018. We didn't win it, but yeah. So I think that is all for now. And thank you for listening to me. Thanks. Thank you for your time.
Thank you, Nav. So that's oh, and everyone's clapping. So that's great. It was worth it just for that. Now that's a really sort of fascinating story, and it does feel like the accolades are well worth the effort and the intention that you had with this app, and it's ongoing. That's the important thing. It feels like it is going to continue, that it's there to be developed, because it's all about funding, isn't it? Especially, and you want it to be free to public, which it is. So it feels like you have ongoing funding and the aspirations for it to extend beyond the current geographical area.
That's right. So currently, so we are funded by the NHS Devon. So you can see, so this funding was made available last year in September, and continues till next year. So another 1 year to go. But the funding comes from NHS Devon, but we provide the same service to the other trusts as well, which are in Cornwall and which are in Somerset. So basically, the idea is, obviously it is not a commercial kind of venture. So we are there. The university is interested because of the data, and also, some university work is leading to hopefully some impact. But there are costs, obviously, the platform development costs and the apps, those are not, and therefore, funding is also needed. So hopefully, we can think of a more, going forward, a more sustainable model where the trusts which are participating also make a contribution for its upkeep.
Okay, that's fair enough. I have got a couple of questions I've raised, which I'll turn to in a sec. But the idea of reducing the number of people who attend emergency departments or A&E departments has obviously this has been a really key agenda item for such a long time. I can remember on my sort of dad's their kitchen wall there'd be sort of chart saying, do you need to go to A&E? Are you this? Are you that? And the other. And of course, my parents were the kind of people who wouldn't dream of going to A&E unless it was absolutely essential. So they probably, it was like sort of preaching to the converted. But for other people, I guess it's just a useful visual reminder. I was thinking also about the audience for this in terms of it being an app, and probably some of the people who are going to be using this app currently, and so when it's extended across the country, will be people who use their phones. I not my dad who does not use it. So, but I would do it on his behalf. So it's sort of it still would have the same effect. Okay, we've got a couple of minutes now. I'm going to share my screen because we had a couple of questions which people have put onto the Menti. And I think I'm sharing my screen now. So the first one is a nice one. So I think one or two of these were posed earlier in the presentation, so you may have covered them in your in the rest of it. But so the first one, which says this is brilliant. Obviously, it is. We're all very impressed with this, and the fact that it's having an impact as well that you can demonstrate, which is very important if you're looking for things to be funded going forward. Can I put our acute care commissioners in your direction for a follow-up? Assuming that I can pass on your email.
Yes,
okay,
please.
excellent. So I will do that. I'll attach it if it's okay with you. You won't be inundated, but I will put your email and make that available for people if they want to follow up afterwards. The next point here. So there are 6 here. Are you pulling live data? If so, where from? Can it be fed from Shrewd?
Yes. So we are pulling the live data. Actually, we are not pulling. The data is being pushed to us from the what we call as the A&E patient flow systems, right? Like Epic, Patient First. Now, what I understand from Shrewd is that Shrewd also either pulls the data from the same systems or it is pushed to Shrewd system, right? So we have not yet used Shrewd. No trust at present, including those who are using Shrewd, are using that method. What they are currently doing is that they are pushing it directly from their patient flow system. Because in this context, Shrewd is a layer in between. So we don't have that layer in between, right? So they are pushing the data directly to us. But having said that, because many trusts are now using Shrewd, and thank you very much for the question. This is something we may look at doing because it might mean less work for people to do the integration because the data is already coming to Shrewd, and if Shrewd can push, but we do not pull information because we don't have that access to the NHS systems and firewalls and all. Data is only pushed to us. Yeah. Does that answer the question?
It was my question. That's really helpful. Thank you.
Thank you. So shall I take the next question? I can take the next question, or I don't know. I think Rachel. Maybe I can take I think I've lost Rachel. So I can take the next question with the 111. So
sorry, I've got to hear me. Yeah, hear me? Yes. Yeah.
Yeah. So with 111, what we are doing is that in my slides, I have mentioned a person called Sebastian Lawrence from NHS Digital, or whatever it is called now. So we are working with him to see what more can be done with the NHSquicker feed, including what you mentioned, people from 111, the people who are triaging the phone call have live access to it. So the thing is that you can go to nhsquicker.com/app, and you can see the app in your browser as well. But to integrate with 111, then it has to be again regional rather than a national solution. But we are thinking of doing that. And also with the paramedics, they're tough books. If we can provide them some feeds, NHSquicker feeds, and again, if for let's say Southwest Ambulance Trust, who are part of the project, so that it might help with ambulance diversion if needed. So those are ongoing, and those talks are with NHS England and with Sebastian. Another question: does travel time have public layer feeds as a layer? So yes. So what we have done with the travel time is that we are using Google Maps APIs, and based on what is chosen, right? We get the data from the live data feed from Google Maps API, and that is what is then used. And then obviously, like in Google Maps, you can say driving or walking, cycle, public transport, and it will change accordingly.
Yeah, sorry to leave you to look at the questions, but all by yourself there. My internet is it's being very, very, very naughty today. So we have actually reached 12 o'clock, and I know we have a couple more questions to go, but I think if it's okay, with our audience with their tummies rumbling and going off to other meetings and so on, if I were to share these questions with you afterwards, just the last two, I know it feels like I know you're desperate to answer them. I can tell that, but you will get your chance. You will get your chance, and
sure.
So I'd just like to. So I'll finish up today, and I will just say thank you so much for coming to share this with us. I've really enjoyed the presentation, and it feels like it's a really positive app and sort of thing that you've been developing there with so much potential, and it just feels like it's the right thing to do right now, and lots of people will be interested. If they haven't already contacted you, they will do. So thank you very much. I look forward to having an update on it in six months time, just to see what progress you're making with it. And to everybody else who's still here, thank you very much for coming. I'm sorry my internet is dodgy. I feel like I should blame my husband, but I know that it's entirely not fair. So I blame Halloween. I don't know what it can't possibly be my fault. Great. So thanks ever so much. Now thank you everyone for coming, and I'll see you all in 2 weeks' time. Thank you.
Thank you for the invitation. Bye-bye.
Bye-bye.